Hi there, Farmies. It's Dr. Sloan, and we are going to talk about heart failure. In the United States, 1 in 8 deaths have heart failure as a contributing cause. Women have higher mortality from heart failure than men. Interestingly, African Americans have a 1.5 to 2 time increased incidence of heart failure as compared to, oh wow, Caucasians, which is spelled very, very wrong. 50% of those who develop heart failure die within 5 years of diagnosis. So you can see that it's a pretty big problem for us in the US. So what is heart failure? I feel like heart failure sounds so dire. And it sounds like it's already happened. Like heart failure occurs when the heart has failed. But heart failure is actually a condition, it's a process of having a heart that is failing, a heart that can no longer pump blood to meet the body's demands. And it's caused by anything that impairs the heart's ability to A, receive blood, case of getting blood in the door to the heart, or B, eject blood. And that is the same as squeezing, right? The contracting of the heart that sends blood out into the body. And we have learned now that that is cardiac output, which is stroke volume times heart rate. Heart failure is also a normal consequence of aging. And so, you'll hear people say, oh, they died of old age, like the Queen. And my guess is that there's some heart failure there that is occurring. It can be caused or accelerated by coronary artery disease, heart valve problems, myocardial infarction, hypertension, diabetes, and dyslipidemia. Now, if you think about it, coronary artery disease is going to make it so that when the heart pumps, not only does the heart have to pump to get blood out of the ventricle and into the aorta, but now it has to push against that resistance that's created by those plaques out in the arteries. So instead of having nice, smooth, happy, pliable arteries, instead we have these, atherosclerosed, hardened arteries, and that makes things stiff. And so the heart is pumping against that stiffness. Heart valve problems become more of a receiving blood issue. Heart valves help move blood from one chamber of the heart to another chamber, from one area of the heart to another area, like from, let's say, the right ventricle into the pulmonary arteries. And so that valve right there, that pulmonic valve, if that valve isn't nice and flexible and the flaps don't open and close and snap shut the way they're supposed to, that can create resistance against which the heart has to push to get blood past that valve and into the lungs. A myocardial infarction means that the heart pump itself, the heart muscle itself, has actually sustained damage, usually a period of a lack of oxygen, which we call ischemia. It's actually ischemia is a lack of blood, but it's the oxygen in the blood that the heart needs. And so a piece of the heart, the wall, the muscle wall will die. And so now your pump is broken, so to speak. There's a part of it that's not working well. Hypertension, we just spent a lot of time talking about hypertension and how it creates increased vascular resistance against which the heart has to pump. Diabetes, which tends to lead to hypertension and coronary artery disease and atherosclerosis, is a precursor to heart failure. And then dyslipidemia, which is something we've also learned about, can cause, again, the accumulation of these atherosclerotic plaques that then cause difficulty for the heart. So there's two main factors that affect cardiac output. And those two factors are preload and afterload. And I believe that you've been learning about this a little bit in some of your other classes as well. But preload is the degree to which heart fibers are stretched just prior to contraction. So it's during that time when, like, let's say the left ventricle is filling up with blood, right? And then it's stretched. And so what is the preload? What is affecting preload? And so the more the heart stretches out, the greater the force of contraction, right? Think about like a rubber band. If you only take it and stretch it a tiny bit and let go, it may not even go anywhere. It may just sort of, circle around your finger and that's it. But if you take it and you stretch it way back and you let go, it'll really snap and that thing will fly across the room. So it's similar with the heart. The more we stretch that heart, the better it gets at snapping back. But there is a point of kind of no return at which we've stretched it beyond its ability to stretch or to pop back into place. And so then the heart sort of becomes flabby and it loses its ability to really contract well. So some drugs actually affect contractility, and we're going to talk about these in a little bit. We sometimes will call these inotropes. Even though they all have names, we just say, yeah, this drug is an inotrope. It really helps with contractility. Now, afterload is the degree of pressure in the aorta that must be overcome for blood to be ejected from the left ventricle, right, out into the body, into the aorta. So the most common problem affecting afterload is hypertension. And that makes sense, right? That increases peripheral vascular resistance, and the heart has to pump against that to get blood out of the ventricle and out into the body. The high afterload caused by chronic hypertension causes a constant increased workload on the heart, right? Because chronic hypertension doesn't go away. So the heart is constantly having to work kind of extra hard to pump past that resistance caused by the hypertension. This can lead to something called cardiac remodeling. So this increased workload of the heart over time, believe it or not, leads to weakness. So it's kind of an odd concept, right? Because we think, wow, if I go out and exercise, I'm working my heart and that's good for me and that makes my heart strong. Well, that's true. But again, the body compensates, right? It goes up and down to meet the needs of the body. And the heart can pump faster, it can pump harder. But then exercise ends and we're done. If the heart has to pump harder all the time, and there's that increased workload all the time, then we begin to have heart weakness. So left-sided heart failure, which we often call congestive heart failure, means that the ventricle can't eject all of the blood that's in it. It fills up with blood, and instead of squeezing hard and pumping it out to the body, it can't squeeze all the way, so it doesn't get all the blood out. And then surprise, as soon as we're done pumping, what happens again? It begins to fill again. So now we're trying to pump, but we can't, we can't get it filled back up. And that inability to stretch out those fibers, again, makes it hard for the heart to pump. So excess blood accumulates in the ventricle, and eventually, over time, the wall of the ventricle thickens and enlarges. It's called hypertrophy. It's like overdevelopment, overfeeding, overgrowth. And over time, the size, the shape, and the structure of heart cells themselves change. And so the myocytes, the heart cells, are injured by this excessive workload and they die. And so as they die, scar tissue forms between these dead cells, and ultimately it makes the heart stiff and inflexible. Okay, think of like if any of you have ever had a rubber ball, kind of the ones that you would use for like dodgeball or kickball. Those balls are great, right? Especially when they're new, they smell good, they're all soft and bouncy. But over time, they harden and they get dry and they get worn out. And they don't bounce as far, and they don't, they're just not as much fun to play with. And this is kind of the same thing that happens with the heart. So the thing about left-sided heart failure, though, is, blood has to go somewhere. So if the blood is trying to go into the left ventricle, but the left ventricle is full, then that's going to kind of fill up and it's going to go and back up into the lungs. And when blood gets backed up into the lungs, you're not going to have blood in your lungs, but you're going to have blood in the lung tissue. And just because it's sitting there, you're going to have fluid that crosses across into the alveoli. And now you have congested, wet lungs, and it makes it hard to breathe. Okay. So this is what we call congestive heart failure. Patients short of breath, coughing, wheezing, they have exercise intolerance. And the problem is that, if it happens long enough and it's bad enough, it's irreversible. Now, right-sided heart failure, which is a lot less of what we're going to be talking about in this particular lecture. We're mostly going to focus on left-sided heart failure. But right-sided is where blood backs up into the veins, like the vena cava, right? So backs up in the veins, backs up in the vena cava, and it results in peripheral edema and engorgement of organs such as the liver, which gets bogged down with blood. I don't know if you've learned about jugular venous distension yet, but where you actually see the jugular, pulsating, that also can be from right-sided heart failure. Oops, wrong direction. So over time, medications and lifestyle can really help maintain heart failure patients. In fact, some can be kept in an asymptomatic state for many years. Asymptomatic means technically you have heart failure, but in terms of how you feel, you actually feel fine. So again, one of these things that can be very silent, it can be developing, patient has no idea that it's happening until boom, now the patient begins to be symptomatic, have heart failure. Eventually the heart can no longer handle the workload. Cardiac decompensation occurs. And again, you get these classic symptoms of heart failure, which is dyspnea on exertion. Dyspnea is difficulty breathing, right? Hard time breathing. Fatigue, because there's not enough circulation happening fast enough to replenish those cells with nutrients and oxygen. Pulmonary congestion, which again manifests itself as difficulty breathing. Peripheral edema. So if blood is backing up from right-sided heart failure, you're going to have big swollen ankles, maybe edema all the way up to the knees. These patients just look puffy and fluid overloaded. It's pretty miserable. And then orthopnea. And orthopnea means that you can't breathe when you're laying down. So this makes it very difficult to sleep. Orthopnea, when you lay down with this, it's going to feel like you're suffocating. And that can cause significant anxiety for patients with heart failure. The pharmacotherapy, or drugs to treat heart failure, have some goals, okay? So it used to be that in the old days, drugs were given just sort of as a palliative measure, just to help people feel a little better, but they didn't really do much to help the heart itself. Now, pharmacotherapy is really aimed at preventing and slowing the progression of heart failure, which is really amazing. And we could go into a very deep discussion of heart failure. There's different types of heart failure, different levels of heart failure. There's all kinds of guidelines for the treatment of heart failure. But for the purposes of your learning in this very first Pathopharm course, we're just going to focus on kind of the general principles of how drugs can help people who do have heart failure. So one of the things that we can look at now is we can look at a biomarker, and a biomarker is just something in our body, some level or some sign or some kind of chemical that we can measure that tells us that a patient is experiencing heart failure. And one of those is natriuretic peptide, BNP. Okay, so BNP is released when you have excessive stretching of the heart muscles, and it's used to determine if someone has had maybe a heart attack, and it also can be looked at as a potential marker for heart failure. So the goals of therapy are to reduce preload, all right, and reduce blood pressure, which is afterload, and then to inhibit the RAS system and vasoconstriction that is caused by activation of the sympathetic nervous system. We're going to talk a little bit more about those when we get into the drugs themselves. So what kind of drugs are used to treat heart failure? Well, ACE inhibitors, diuretics, beta blockers, cardiac glycosides, vasodilators, which we are not going to talk about in this class. You'll learn about them more in Nursing 356. And phosphodiesterase inhibitors, which we will only just barely touch on, but they are used for very end-stage heart failure, usually sometimes as a bridge to waiting for a heart transplant. So ACE inhibitors, you guys know ACE inhibitors. You've learned them for hypertension. They lower peripheral resistance, right, which lowers blood pressure. They inhibit aldosterone secretion, which decreases blood volume. And then they dilate veins. So this decreases pulmonary congestion and it reduces peripheral edema. You've got to know the RAS system. We talked about it during hypertension, but it needs to be something that you spend some time committing to memory so that you understand how and where these drugs work. The RAS system has certain steps. You know, this gets excreted and it gets converted into this, and then this enzyme comes and converts it into this, and then this stimulates the release of that. Those are the kinds of things that you need to learn, and you need to know how it is a cycle, okay? So I put in this great video for you, and I just, you're going to have to get to it by going to the notes version of this recording or this particular PowerPoint. but it's about, I want to say it's about a 10-minute video. And it's done by Nurse Sarah, who's wonderful. She's definitely from the South. And so I love listening to her voice. And she is a phenomenal teacher. Phenomenal teacher. She does a lot of great videos for nursing, by the way, in case you ever want to check her out. Okay, diuretics. Well, you guys have learned this, that diuretics decrease blood volume. They cause diuresis. Water is pulled from the blood and excreted. Water and sodium and sometimes potassium. Okay. Diuretics are only used when there are signs of fluid retention. They, in and of themselves, don't do much for heart failure, whereas ACE inhibitors actually are thought to help with, prolonging life. So anyway, these are often used with ACE inhibitors or ARBs in a combination drug. Beta blockers. Beta blockers are standard therapy for heart failure patients. Beta blockers, as you know, block effects of the sympathetic nervous system on the heart, which slows heart rate and it reduces blood pressure. It reduces workload on the heart. Beta blockers alone can actually improve the size, shape, and function of the heart, even returning it to normal. Now, is that going to happen after years and years of damage? No. But could it happen in earlier stages of heart failure? Yes, and that is super exciting. Cardiac glycosides. So cardiac glycosides are used, and they've been used to treat heart problems for 2,000 years. This is the drug that you hear about a lot called digoxin. And it comes from the purple foxglove plant. And the name for that is Digitalis purpurea, and white foxglove plant, Digitalis lanata. So that's where that word dig or digoxin comes from. Now, cardiac glycosides not only are inotropes, but they're chronotropes. So chronotropes, remember chrono is time. They slow the rate, so they slow heart rate, and they increase the force with which the heart beats. So this positive inotropic effect. And it really improves cardiac output. Here's the kicker with cardiac glycosides like digoxin, which is going to be our prototype. They have a very narrow therapeutic index, and it is very easy for patients to become toxic while taking them. So we'll talk more about that when we actually get to the prototypes themselves. Phosphodiesterase inhibitors. This is the last category that we're going to talk about in this lecture. These are drugs that are basically used either for a medical emergency where the heart is temporarily in heart failure, okay, and the heart needs some help, or we are very much at end stage heart failure, maybe hoping for a heart, for a heart transplant, okay? So these are used as a last ditch effort. They have lots of toxicities and other things with them. We'll talk about them more, and they have a very elegant mechanism of action. But suffice it to say that the way these work is that they block the enzyme phosphodiesterase in cardiac and smooth muscle, and it increases CAMP and CGMP, which results in this positive inotropic effect, helps the muscle contract better, and vasodilation. And those two things together are very helpful for heart failure. Okay, gang, that's it. We will talk in class.